Good morning and good afternoon to the audience, and thank you for joining our symposium on trauma and perinatal mental health. As you might have heard from previous speakers, maternal psychiatric morbidity is relatively common in the peripartum and postpartum period, and we usually label these conditions under the umbrella of peripartum depression. However, in recent years, there is growing appreciation for sometimes co-occurring conditions, and one such condition is PTSD evoked childbirth, which is the focus of my research. PTSD could be regarded as a fear-based disorder and is commonly associated with combat veterans. The uniqueness of PTSD is that it's triggered by exposure to a specific traumatic event. One might ask, why will childbirth trigger PTSD? Well, in many cases, women appraise a childbirth experience as highly stressful. There is a sense of helplessness and sense of loss of control. And in fact, in our study at Massachusetts General Hospital, we found that as much as 20% of women think that they felt that they thought that they would pass out during the course of giving birth. Additionally, for some women, there are objective stressors in which there is a real concrete threat to their life. An example of objective stressors might be obstetrical complications, including severe blood loss. Together, the objective and subjective stressors increase the likelihood that a woman would develop childbirth PTSD, which I would refer from now on as CB-PTSD. CB-PTSD in community samples, the rates usually are reported between 3 and 6%. However, if you consider women at high-risk groups, such as women who experience objective stressors in birth, for example, in our study of women who underwent unplanned cesareans, then the rates are much higher. If you look at the lower right part of the slide, you'll see that women who have unplanned cesarean present with CB-PTSD rates as much as 20%. So kind of roughly 1 out of 5 women is likely to develop CB-PTSD following unplanned cesarean. Thus, these heightened prevalence rates are equivalent to PTSD rates we see in samples of individuals exposed to interpersonal trauma. The uniqueness of PTSD in comparison to other forms of trauma or other forms of PTSD is that in childbirth PTSD or CB-PTSD, the child can become a traumatic reminder of the childbirth experience, which therefore would mean that the child could provoke mother's PTSD symptoms. Avoiding the childbirth traumatic cues, which would include the child itself, is potentially a core feature of PTSD. As we know, avoidance is a core feature of PTSD, and avoidance would therefore lead or result in the mother distancing herself from the baby. As you can see on the right side, in a study of over 600 women, we found that women who are endorsing CB-PTSD report lower bonding with their baby in comparison to those who do not report CB-PTSD. Therefore, the importance of accurate screening of women who have the condition is not only important in order to improve the mother's health outcomes and her mental health outcomes, but also to improve the long-term trajectory of her child and how that child develops. One way of developing more objective screening for CB-PTSD, which currently, as I'm sure you know, we usually rely on subjective self-report assessments or clinician assessments, which could be also subjective to some extent, is by employing more biological-oriented measures to assess the severity of the CB-PTSD symptoms. The severity of PTSD symptoms in general has been studied for many, many times by employing a physiological paradigm, which has been studied among individuals who were combat veterans and presented with PTSD. In this physiological paradigm, we measure heart rate, skin conductance, and EMG frontalis when the survivor imagines their traumatic childbirth experience. When the survivor imagines their trauma experience. We modified this paradigm to assess the severity of CB-PTSD symptoms. And basically, mothers were asked to provide a short script, a short narrative of their childbirth. That narrative was revised into a short script. And then we asked mothers to imagine their childbirth experience. And during the imagery paradigm, the imagery phase, we assessed physiological activity. Physiological activity basically implies the ratio between the sympathetic and parasympathetic tone. And we measure physiological activity not only to mothers' recollection of their childbirth experience, but also to a positive event, a trauma event, and neutral event, because we really wanted to understand the physiological activity, which is only associated with the trauma recollection of the birth. And our sample included women who had PTSD or not, only women who underwent a traumatic childbirth experience. Women presented with CB-PTSD showed heightened physiological activity when they recalled their childbirth experience. Heightened physiological activity was seen in terms of heart rate, skin conductance, and EMG corrugator. As you can see, the physiological activity of the mothers who had CB-PTSD, with kind of presented here on this slide on kind of this reddish, was higher than physiological activity of controls, and was even higher than physiological activity reported in studies of combat veterans. Combat veterans in my slide are presented in the dotted line. So basically, these findings offer strong validation for a CB-PTSD condition which is triggered by the childbirth experience. Women who present with CB-PTSD have physiological alterations like individuals who are exposed to combat war and develop PTSD. More so, it might be that kind of we might be able to consider these kind of physiological alteration, how we can measure physiological activity as in kind of some kind of a device that will be developed to use in postpartum units. We further found that the mother's physiological activity was associated with their bonding behavior. Basically, the same sample of mothers was invited to a follow-up visit, which took place on average 5 months later than the initial physiological activity recollection visit. And we assessed bonding behavior by an objective paradigm in which we asked mothers to freely interact for 5 minutes with their babies. And we found, as you can see on the left side of the slide, that the PRP score, which represents the average composite score of the physiological domain scores, the PRP score, which is kind of the overall physiological activity of these mothers, was associated, the more physiological activity indicated less maternal sensitivity towards the baby. And the more physiological activity indicated more intrusiveness towards the baby, suggesting that the core physiological alterations in CB-PTSD not only underline the PTSD symptoms of the mother, but also potentially mediate bonding impairments. We further brought the same sample and assessed their neural alterations during the script-driven imagery paradigm. So kind of we had mothers recall their childbirth and then we read the fMRI outputs. Amygdala is an area in the brain that is responsible for fear processing. We found that women who present with CB-PTSD, during the recall of their childbirth experience, there is an overactivation of the amygdala in comparison to control. And more so, this heightened amygdala activation, again, is associated with bonding impairment. As you can see on the left side of the slide, heightened amygdala activation is associated with less maternal sensitivity towards the baby. On the other hand, heightened amygdala activation is associated with more maternal intrusiveness towards a child. Once again, suggestion that the physiological and neural alterations that we see among mothers who present with CB-PTSD are not only kind of potentially the underlying biological mechanism that account for their PTSD symptoms, but also mediate their difficulties taking care of their young. I wanted to end my presentation by sharing with you preliminary results of our COVID-19 survey. In this study, we recently, which was launched in early April, and now includes more than 300 women, we set to study whether COVID-19 adds another stressor to the childbirth experience. And we, in a group of roughly 1,200 women, including 630 who gave birth before the pandemic and 630 who gave birth after the pandemic. And these women were matched on various background, childbirth, and when their postpartum time point assessment was taken, we wanted to see whether there are differences in acute stress response to childbirth. And we found, as you can see on the left side, that mothers who gave birth since the outbreak of the pandemic, they report that their childbirth experiences are more traumatic than those who gave birth before the pandemic. And here we assessed traumatic childbirth experience by the Peri-Traumatic Distress Inventory, which is really a measure to assess acute traumatic stress responses. And we use the cutoff of above 16, showing that in the course of the pandemic, there is women who recently gave birth are likely to endorse acute stress symptoms at the clinical level, more so than women who gave birth before the pandemic. And as you can see on the right side, this acute stress response mediated their subsequent endorsement of CB-PTSD symptoms and also problems with taking care of their babies. Thank you so much, and I hope there will be kind of a lot of interest and attention in kind of further understanding childbirth PTSD, especially in the context of the current pandemic.